In nursing, a single decision, it can be the difference between life and death. So let's break down exactly how expert nurses think under that kind of pressure. We're going to give you the mental tools you need to stay in control when it matters most.
Okay, picture this. You walk into a room and your patient is clutching their throat, gasping for air. Your first instinct might be to panic, right? But the thing that separates an expert nurse from a novice is having a clear mental roadmap. So let's start building that map right now.
All right, section 1. A patient is crashing. When this happens, it just feels like pure chaos. But to an expert nurse, it's really just a puzzle that needs to be solved, and fast. In these moments, having a mental framework isn't just helpful, it's the only thing that separates control from total catastrophe.
Now we're diving into the most critical part, the first 60 seconds. Look, before you can diagnose anything, before you can even really think deeply about the problem, you have to act. And these first seconds are governed by one rule and one rule only. The ABCs: airway, breathing, and circulation. These are your absolute non-negotiable first moves.
So let's start with A for airway. You're at the bedside. First thing, you ask them, can you speak? If a patient can talk back to you, you know they have a clear airway, at least for now. But if they can't, you're immediately looking inside their mouth for any obstructions, and you're leaning in, listening for any sounds. Every single second counts here.
And this is where theory just becomes muscle memory. You hear a gurgling sound, you suction, no hesitation. You hear stridor, that high-pitched, terrifying sound that means the airway is closing, you're hitting that rapid response button. And if you hear nothing at all, you start the Heimlich or CPR. These aren't suggestions, they are immediate, life-saving reflexes.
Okay, the airway is clear. Let's move on to B for breathing. Now you're looking at their chest. Is it rising and falling? Is it shallow? Is it deep? What does that effort look like? You immediately get a pulse oximeter on their finger to check their O2 sat, and you grab your stethoscope to listen to their lungs. You're gathering all this critical data in just a few seconds.
This right here is the act first, document later principle in action. You see no chest rise? That's a code glue, and you're starting to assist their breathing with a bag valve mask. If that O2 saturation drops below 90%, your first move always is to apply oxygen. The patient can't wait for you to chart.
Airway's open, they're getting oxygen. Now for C, circulation. The big question is the pump working? You check for a pulse. If it's thready and weak, you go for a central pulse like the carotid in the neck. Then you get a blood pressure and do a quick head-to-toe scan. Is there any obvious active bleeding anywhere?
And you see, the logic is always the same. No pulse means their heart has stopped. You start compressions immediately. A super low blood pressure, you lay them flat to get blood to their brain and you call for backup. You see active bleeding, your one and only job in that moment is to apply firm, direct pressure. And just like that, you've stabilized the immediate threat. Now you can finally take a breath and start to think.
So we've managed that initial 60-second crisis with the ABCs. Now we get to zoom out and look at the mental models that guide an expert nurse's decisions from this point on. This is the next level.
After you've got the ABCs locked down, your brain's next filter is Maslow's hierarchy of needs. This is a classic, but it's crucial. It reminds us to always prioritize the body's most basic physiological needs, things like oxygen, fluids, nutrition, to keep the patient from sliding backwards. You're basically building a stable foundation for them to recover on.
And layered over every single thing you do is safety. This should be a constant mental checklist that's just running in the background. Is the bed locked so they don't fall? Did I just wash my hands? Is the oxygen tank I just grabbed full, or is it almost empty? These seem like small things, but they prevent common and sometimes deadly mistakes. Now, let's say you have multiple patients. Who do you see first? The answer is always the unstable patient. So, what makes a patient unstable? It's someone with a new, unexpected, or life-threatening change. Think sudden confusion, weird vital signs, or that crushing chest pain. That patient will always take priority over someone who is stable with a chronic, predictable condition. Okay, let's get back to our patient. They're stable, for the moment, thanks to your quick work with the ABCs. But now, new information is flooding in. The lab is calling with critical values, and your team is looking to you for what to do next. This is where those really high-level priority decisions get made. So the lab calls and reports a potassium level over 5.5. This isn't just some number on a screen. It is a blaring fire alarm going off in your head. High potassium can cause a lethal cardiac arrhythmia. This information immediately jumps to the very top of your to-do list. You have to act on this now.
Next, you see their blood glucose is less than 70. Again, total emergency. You have to remember the brain runs on one thing, glucose. Without it, your patient can suffer irreversible brain damage and quickly. This requires immediate intervention.
And then you get a hemoglobin of less than 7. The best way to think about this is like trying to run a major city with half the number of delivery trucks. There just aren't enough red blood cells to carry oxygen where it needs to go. This is a critical circulation and oxygenation problem, and that patient is likely going to need a blood transfusion, fast.
Now, in the middle of all this chaos, you've got to delegate. But what can you safely hand off? Well, with an unstable patient, the rule is actually pretty simple. The registered nurse, that's you, must do all the initial assessments, all the evaluations of data, and give all the IV medications. You just can't delegate tasks that require your clinical judgment, especially not when someone's condition is changing by the minute.
Okay, now for the grand finale. Let's tie every single thing we've talked about together. We've gone from the first 60 seconds of chaos to complex decision-making. Here is a single, powerful formula that you can use for pretty much any nursing scenario.
This right here, this is the entire thought process. First, always, are the immediate lifesavers, ABCs. Then, you build a foundation, Maslow and safety. Next, you figure out which patient to see first, the unstable one. Then, you handle all the incoming data, address critical medical issues, delegate what you can, and act on those critical labs. And finally, you are constantly monitoring by interpreting their vital signs. This is your roadmap to thinking like an expert.
So let's go back to our patient. You've navigated the crisis, not with panic, but with a clear, logical framework. The chaos is now under control. So the only real question left is, are you ready for whatever comes next?